So these are just some of the secondary causes of diabetes. Let's move on to the diabetes insipidus, which is you all know people can present with fatigue, and this can be because of either central diabetes or nephrogenic diabetes insipidus. And central diabetes insipidus would be due to ADH deficiency, which can be because of either tumor or autoimmune disorder or trauma or something, anything like that in the brain. Nephrogenic diabetes insipidus is almost always because of ADH resistance, and the people will have symptoms of polyuria and polydipsia, just these two symptoms, and as a result of that they just have a whole lot of dilute urine. That's how they basically present. So when you check their urine, they have low urine specific gravity, they have low urine sodium, and they have high plasma sodium. So that's kind of the way to make the diagnosis of diabetes insipidus. The other thing is that lithium is the most common drug that's going to cause nephrogenic diabetes. So always keep that in mind. Lithium, I know you haven't covered it because you haven't done the FOBs yet, but lithium is an antipsychotic drug for bipolar disorder, but just keep lithium in mind because it's going to cause diabetes insipidus. And then there are some other drugs too, for example demiclocycline, but we don't use that very much, so just remember lithium. Basically these patients, if you were to summarize it, these people just have a whole lot of dilute urine. That's how you remember diabetes insipidus. And the difference between this and diabetes mellitus would be that diabetes mellitus patients don't necessarily have a low specific gravity, so their urine is not going to be dilute. It's going to be more glycemic, concentrated. Okay, so we are now on calcium. So basically this is just kind of the way calcium is in the body. So 15% of the calcium is going to be 45% of the calcium is going to be free or ionized calcium. That's what you can calculate. You can also get the total calcium. 40% is going to be bound to albumin, and 15% is going to be with some other anions. So we are primarily concerned with the free calcium when it comes to clinical symptoms. So this is just a quick graph showing, it's basically from up to date. Basically it's showing how calcium metabolism really works. So in your patient who has normal, who doesn't have any problem, your total serum calcium and PTH are going to be dependent upon each other, just like this. So if they have a high calcium level, the PTH will drop, and vice versa. People with primary hyperthyroidism, which is one of the very common causes of hypercalcemia, in these patients your calcium will be high and your PTH will be high as well, because PTH is doing it. So the negative feedback is not working. Patients with hypercalcemia of malignancy, they don't have high PTH levels, but they have very high calcium levels, and PTH drops. And then people with hypoparathyroidism, who just have some destruction in the parathyroid gland, they have very low calcium as well as very low parathyroid levels. So that's how this graph kind of shows. But we'll talk more about all of these causes here in a second. This is just a calcium kind of effect of calcium on different on parathyroid, and then effect of parathyroid and calcitriol on calcium and phosphate metabolism. But I will just move on to the next one real quick. So what happens with hypercalcemia? People can have fatigue, and then in addition to that they have bones, stones, moans, and groans. Basically what this means is calcium is going to be high, they have fatigue and confusion. So that's how you know they maybe have some moans. People have nausea and vomiting, usually abdominal pain, chronic abdominal pain, and then they also can get constipation, and in some cases they can get pancreatitis. So one of the causes of pancreatitis is hypercalcemia. So you can see how if you are evaluating a patient with chronic abdominal pain and you just can't figure out what's causing it, and all the workup for the different causes of abdominal pain is negative, then you might want to pay attention to their calcium levels, and especially if they have constipation too. So that's how you will get a clue in the history. Patients can also get some bone pain with hypercalcemia, and they can also get some osteoporosis. People can also get some nephrolithiasis. So very high calcium levels will cause kidney stones, renal insufficiency, and that's why we call it stones. And people with hypercalcemia can also get short QT syndrome, so that's just an EKG abnormality. This is not always present, so it's not one of the most common causes of hypercalcemia. Common results or consequences of hypercalcemia. That's why it's not in the mnemonic here. So now we will talk about symptoms of hypercalcemia. So people with hypercalcemia can come in with fatigue as well. In addition, they may have symptoms of bones, stones, moans, and groans. And so as far as the groans is concerned, they may that's basically neuropsychiatric symptoms. So they may just have confusion and some of the other psychiatric disturbances. People can also have nausea, vomiting, abdominal pain, constipation, and pancreatitis. That can happen with hypercalcemia. So that goes along with moans, and people will. So now we will talk about hypercalcemia. So people can have bones, stones, moans, and groans, and they can come in with fatigue and any of these 4 symptoms. So as far as groans is concerned, they basically have fatigue and confusion, so some of the neuropsychiatric disturbances. People can also have nausea and vomiting and constipation, so that goes with moans, and some abdominal pain as well. And with hypercalcemia, one of the causes of pancreatitis is hypercalcemia, so keep that in mind. If they come in with severe abdominal pain that is just unrelenting and a lot of vomiting, then obviously you're going to look for pancreatitis. And then if that is the diagnosis, and of course you're not done there yet, you will need to figure out what caused pancreatitis. So the most common causes of pancreatitis are alcohol and hypertriglyceridemia, but then hypercalcemia is one of the causes as well. So when you do their labs and the calcium is high, then this will give you a clue that maybe this caused pancreatitis. Anyhow, people with high calcium can also get bone pain, so that is another very common symptom of hypercalcemia, sustained hypercalcemia. People can also get kidney stones, so they basically have renal insufficiency if there is sustained nephrolithiasis, so people can develop renal failure in the end. And then finally, people have one of the less common features or consequences of hypercalcemia, which is short QTs. So remember, high calcium will cause short QT and low calcium will cause long QT. So treatment, of course, the acute treatment for anybody who comes in with really high calcium level, for example above 11, they will need to be hydrated. So intravenous hydration will need to be given. That is one quick way to dilute the calcium level from in the body. But then of course, if somebody is taking any medicine, for example lithium or thiazide diuretics that can cause hypercalcemia, that drug needs to be discontinued. So we'll talk about that here in a second, but basically the bottom line of the treatment will be hydration. So you'll give them a lot of fluids, and that's how some of the acute symptoms will resolve, but then of course chronic management will need to be done later on. So just a quick thing about hypocalcemia. Although people don't usually typically present with fatigue when they have hypocalcemia, but just because it's opposite to hypercalcemia, I am putting it here. So basically they have no rhythm in heart or muscle, and they have no sense and no length. So this is how you can remember the mnemonic. They have a lot of neuromuscular junction problems. So they have basically tetany, paresthesia, carpopedal spasm, and you're very familiar with Trousers sign and Shovstick sign, which are basically a neuromuscular overactivity or irritation, and then these people can also develop seizures. So these are the symptoms of hypocalcemia, so just keep that in mind. And then people can have long QT and some arrhythmias with hypocalcemia as well. People can develop dementia, Parkinson's disease, and some basal ganglia calcification with low calcium levels. And then people can also finally get some cataract. So all these things will happen with hypocalcemia. So you can see no rhythm in heart or muscle, and then there is no sense and no length. So that's how you can remember this. All right, so now let's look at different causes of hyper and hypocalcemia, and clinically how do they present. So people, one of the very common causes of hypercalcemia is primary hyperparathyroidism. So it can be either parathyroid adenoma or parathyroid cancer. And in this case, your calcium and parathyroid and vitamin D are going to be high, because that's what PTH is going to do. There is no negative feedback, or negative feedback doesn't work because the gland is just overriding all the negative feedback. So that's how all these three things will be high. Your phosphate, on the other hand, will be low, or maybe low normal, because your PTH is going to negatively affect phosphate. Then in secondary hyperparathyroidism, which is one of the most common causes of hyperparathyroidism, is renal failure or chronic kidney disease. When people have their kidneys not working and creatinine starts to rise up, then they develop secondary hyperparathyroidism. Because why? What happens with bad kidney function? Your calcium level drops, so you have low calcium and low vitamin D, and as a result, body tries to compensate, and parathyroid hormone will rise, and also will the phosphate will be high anyway because of the renal failure. So the feedback loop is working in this case, but the kidneys are not working. So that's how that drive is going to raise the parathyroid levels. And then both of these, combination of these features will cause renal osteodystrophy. So that is why these people are at higher risk for osteodystrophy. And then your extra neoplastic manifestations of cancer, if you have a non-parathyroid cancer, so not parathyroid cancer, but non-parathyroid cancer, some of the cancers can release parathyroid hormone related peptide. For example, small cell cancer of the lung can do it. Some of the others can do it too. But anyhow, if you have PTH related peptide, which we don't usually initially check for in patients, but this would be something to look for if you're suspecting that maybe this is causing hypercalcemia. So in this case, your calcium and vitamin D are going to be high, just like primary hyperparathyroidism, but your PTH and phosphate both will be low, because here your negative feedback loop is working. Your calcium and vitamin D are telling the parathyroid gland, hey, I don't need you anymore, we don't need you so PTH will start to drop, but the related peptide, which is basically the I guess the sister PTH, will continue to work and will cause all these abnormalities, and phosphate will be low or low normal. Then one of the most common disorders that we see in clinical practice would be vitamin D deficiency. So basically, a huge population in the US is low in vitamin D. I don't know the exact number, but I know it's definitely above 75%. A lot of people are low in vitamin D, and what happens in these patients? There, of course, vitamin D is low, calcium will be low as well, and then because of that, they may have high parathyroid hormone levels. So their body constantly tries to compensate for this low vitamin D levels and low calcium levels, and that's how their PTH and phosphate will start to go up. Again, phosphate may be normal or low or high normal. People with vitamin D toxicity, they have this is not a very common problem. It will occur if somebody is just in the sun on the beach all the time, but also can occur when we give them the vitamin D. So we can prescribe vitamin D. If we do too much of it and we don't monitor vitamin D levels can go up. So their calcium and vitamin D level will rise, because vitamin D is high, calcium will rise too, and phosphate will rise too as a result, and parathyroid hormone level will be low. So next is drugs. This is another very common cause of calcium abnormality. So some drugs like lithium and hydrochlorothiazide, these two, the diuretic and antipsychotic drug, or a drug that is used for bipolar disorder, this can cause rise in calcium level and vitamin D level. So primarily calcium will be high, and as a result is going to cause negative feedback, and parathyroid hormone will be either normal or low normal, and phosphate will be normal or low normal. Then finally there is familial hypocalciuric hypercalcemia. In this case, calcium is high, and parathyroid, vitamin D, and phosphate will be normal. So if you have everything normal but calcium is high, and usually it's not super high, it's like slightly high, so it's not in the range of malignant hypercalcemia, but then you must think about familial hypocalciuric hypercalcemia, and urinary calcium will determine or make the final diagnosis for this. So here is a table showing that there are different disorders: parathyroid adenoma, parathyroid cancer, renal failure, non-parathyroid cancer, vitamin D deficiency, vitamin D toxicity, drugs, lithium and thiazide, and familial hypocalciuric hypercalcemia. And here are different levels, calcium, parathyroid, hormone, vitamin D, and phosphate. So you can just fill this box yourself, or I can do it for you. So for example, if your calcium is high, if your patient has parathyroid adenoma or cancer, which is primary hyperparathyroidism, your calcium will be high, your parathyroid will be high, your vitamin D will be high, and phosphate will be normal or low normal. And in non-parathyroid cancer, your calcium will be high, but parathyroid hormone will be low, or vitamin D will be high, and then phosphate will be normal. So you can see that they are very similar to each other, except that parathyroid is low in the secondary hyperparathyroidism. And then on the other hand, you can encounter 3 other situations where calcium will be high. So in that, vitamin D toxicity, where calcium will be high, and then your parathyroid hormone will be low, and then the other things will be vitamin D and phosphate will be high too. So if you see that picture, you can draw vitamin D levels right here, and that's how you know this is right here, and that's how you know this is vitamin D toxicity. In case of lithium and thiazide diuretic, well, your patient history will give you a lot of information right here that okay, maybe patient is taking these medicines, but in addition, your calcium will be high and your vitamin D will be high too, but your parathyroid hormone and phosphate will be low or normal. In familial hypocalciuric hypercalcemia, your calcium will be high and everything else will be normal. So if you just see one problem, and that's familial hypocalciuric hypercalcemia possibly. The renal failure patients and vitamin D deficiency patients have low calcium. So these are the two where your calcium is low, all the rest calcium is high, and then you can see the rest of the abnormalities. So you can see this circle right here, your calcium is high. This is the only exception where your parathyroid hormone is high with high calcium, and all the others, your parathyroid hormone is either normal or low. And then this is the circle where your calcium is low and your parathyroid hormone is high.